Thanks everybody for tuning in, and we appreciate the JCC hosting us. Tonight we're going to talk about heart disease in general and some important ways that we can reduce overall cardiovascular risk. We're going to talk about how many people in this country have heart disease, what do I mean when I say the phrase, and looking for heart disease and risk factors, and spending a lot of time, in fact, I would say the bulk of the talk, on how important lifestyle is in managing overall cardiac risk. Since 1984, more cardiovascular deaths have occurred in women than in men. 80% of people with sudden cardiac death had no prior symptoms, and younger people are affected too. Heart disease remains the most common cause of death in the United States, despite COVID and despite increasing cancer cases. About 18 million people in the country have coronary disease, which is a problem with the arteries of the heart, and that really amounts to 1 death every 36 seconds, or 1 out of 4 deaths in this country are related to heart disease. If you're over 40, your risk of developing heart disease is almost 50% in men and 32% in women. And really, these statistics apply to all types of folks. What is heart disease? Well, it's a very broad term, but most people think of problems with the arteries, the plumbing that serves the heart muscle. But people can also have problems with the valves inside the heart that open and close and allow blood to move in the right direction. People can have the problems with the electrical system of the heart, or problems with the actual muscle of the heart, and that's usually caused by 1 or more of the above problems. Today, we're really going to focus on problems with the arteries of the heart, or coronary atherosclerosis. This is a schematic of the arteries of the heart, and there are 3 main blood vessels that run over the surface of the heart. They come out of the aorta, and then they take blood to the heart muscle itself. So, what do we have to worry about, and what kind of things should we be mindful of in terms of symptoms that could portend a heart problem? Well, classically, we're taught that people have chest pressure or tightness, maybe shortness of breath, jaw pain or arm pain, or even just nausea or vomiting. Usually when people are having a serious heart problem, they start to sweat, or they could just feel generally unwell. Now, this doesn't mean if you're having any of these, you're gonna have a heart attack, but these are symptoms that are important to keep in mind that could be a sign that the heart muscle's not getting enough blood flow. I wanna show a quick little video that I borrowed from the internet. Again, a little cartoon, but this is zooming in on the left anterior descending artery, which comes down the front of the heart. And there's a blockage there with cholesterol plaque built up. And we'll talk about plaque in a little bit. So this is a cross-section of the artery. And if that plaque ruptures open, kind of like a blister, the body doesn't like that. It's foreign material. So the body reacts to that with inflammatory cells and platelets and clots that off. But a clot in a heart vessel is like putting a dam in a river. So that's a problem. So what we're trying to avoid is plaque rupture and acute heart attacks. That's the thing that we're trying to avoid in my job. Page down. How does this happen, you may ask? Well, there's a lot we have learned in the past several decades, and there's a lot more that we have to learn. But we know that inflammation in the lining of the vessel really plays a key role in allowing plaque to form in the first place, and then allowing that plaque to become unstable and potentially rupturing. And why does a plaque rupture? Sometimes we don't know, but things like high blood pressure or a sudden spike in blood pressure, toxic insults such as using cocaine or using a high amount of stimulants, and stress hormones can make that lining unstable and cause the plaque to rupture. So how do we prevent this? Lots of people have heart problems. It seems like a scary thing and it can be a sudden thing. How do we know if we're at risk and what can we do about it? Well, in the world of preventative cardiology, we definitely like to try to detect somebody's risk and reduce that risk before they have an event. I always like this little cartoon, an ounce of prevention, right? They always say that's better than a pound of cure. So that's what we're going to spend the majority of the time talking about today. So most of you may know that things like having high blood pressure, having high cholesterol or diabetes, smoking cigarettes, vaping, any kind of nicotine product, and probably smoking marijuana as well, a genetic predisposition to heart disease, and being middle-aged or older, overweight, and not taking good care of yourself in terms of exercise are all what we call classic cardiac risk factors, meaning we know, dating way back to the 1940s and the Framingham Heart Study, that people who have one or more of these types of issues are at higher risk of having artery problems, including chronic kidney disease. We're also learning more and more that there are other issues that need to be addressed. Maybe low vitamin D is a link to heart disease, sleep disordered breathing, such as obstructive sleep apnea, which is a very high stress state for the body, other vascular disorders, such as having frequent migraine headaches or Raynaud's disease, autoimmune diseases, because those tend to be more inflammatory, can be linked to heart disease. Also, chronic infections, uncontrolled HIV infection, any history of chest radiation or certain types of chemotherapy can be toxic to the heart. People who have gout, because again, that's an inflammatory condition. And I always ask, or try to always ask my female patients if they've ever been pregnant, and if so, did they have any complications during their pregnancy? Because high blood pressure during pregnancy or having high blood sugar during pregnancy can increase risk later in life. So we follow those patients more closely in terms of their cardiac risk. Also, polycystic ovarian disease due to changes in insulin levels can be a risk factor for heart disease. So we know that these things are out there, and some of us may have these problems and hopefully are getting them addressed and working on that with our primary care providers. But how do we know? What do we look at? Well, in addition to getting your blood pressure checked regularly and your cholesterol checked regularly and knowing what your weight is, for some people, not everyone, but for some people, we actually recommend something called a coronary artery calcium score. And I'm going to show you a picture of that on the next slide. And basically, it shows us if there's any plaque inside the heart. Not all types of plaque, but plaque that's been there long enough to have calcium buildup on it. And that can be a useful tool. We do cholesterol testing all the time, and sometimes we do additional testing on the lab work, such as looking at subtypes of cholesterol or certain proteins on the cholesterol. For example, lipoprotein little a is something that we check in some people, again, not everybody. And we often measure inflammation in the body. Now, if we're measuring inflammation in the body, that's a general measurement. It doesn't mean the inflammation's coming from the heart or coming from the kidney. It just means that there's inflammation. So it can only tell us so much. And every once in a while, we also will look at someone's carotid arteries because it's all one big vascular system. So if someone's got a little plaque in their carotid arteries in the neck, they may actually have plaque in the arteries of their heart too. This is a picture of a CAT scan of somebody's chest, and we're looking up at the patient as if we were at their feet. And you can see, I hope, this white arrow right here pointing to this white plaque. So beyond the plaque, if you can follow my cursor, this is an artery here, and this is an artery here, but all of this white stuff is plaque. So this person probably has a pretty narrowing in their heart, one of their heart arteries. And they may not have symptoms. So these types of tests are tests that we do before someone presents with a heart attack, for example. And this is a picture of an ultrasound of someone's neck artery, the carotid artery. This one's actually normal, but if it were not normal, we would see more thickening along the lining of the artery. Okay, so should everyone go out and get a heart scan and a carotid ultrasound and fancy lab tests? Not everybody. We need to understand kind of where we are and what our risk is, and then have a discussion about it. So I'm a big proponent of everybody understanding what their cholesterol is, if they have diabetes, and what their family history is, and beyond that, we can work with other things. So I use this phrase, in the middle people. So someone who might have well-controlled high blood pressure and cholesterol that's somewhat high but not very, very high, and maybe their father had a heart attack at age 50, that would be the type of person that I would recommend have a little bit more testing, so that we can help understand whether they should be on a statin medication, how aggressive we need to be with their diet, and that type of thing. But again, as I said in the beginning of the talk, the most important thing is trying to prevent coronary disease before it happens, or prevent it from progressing. That's a lot easier than putting in stents and dealing with heart attacks. So what are normal numbers? Well, your blood pressure should be ideally 120/80 or less. LDL cholesterol, so that's one of the subtypes of cholesterol, should be less than 100. And the HDL, which we call the good cholesterol, ideally would be greater than 50 in women and greater than 40 in men. So there's not a lot that we can do pharmacologically to raise HDL cholesterol. Part of it's genetic and part of it has to do with regular exercise, but it's great to have a higher HDL cholesterol. Triglycerides, which are another cholesterol subtype, should be less than 150. Body mass index, and you can plug your numbers into a calculator on the internet, I'm sure, but we shoot for this kind of 19 to 25, and it takes into account your height and your weight and says that's healthy. It doesn't take into account extremes, like a very, very muscular person who might have low body fat is gonna have a higher BMI, but it's a good starting point. Waist circumference should be less than 35 inches for women or 40 inches for men. And if someone has diabetes, they have a lab test that's done every few months called the hemoglobin A1C, which has to do with blood sugar, and that should be below 7%. So knowing where you are and what your genetics are can kind of help us understand what your risk over time might be. And I want to emphasize this slide because I think this is kind of the pinnacle, is how do we get those numbers better? How do we reduce risk? Well, it's not going to come as any surprise. And even in 2022, we don't have, nor do I think we necessarily need, this fancy, glamorous new pill to take care of everything, because we already have a lot of the tools that we need to lead a heart-healthy life. So this is going to be review and maybe basic for some, but I think it's really, really important, and I love talking about it. So nutrition, exercise, sleep, really big proponent of sleep, and I'll tell you about that in a moment, and stress, or low stress. So what should I eat? I'm not a nutritionist, and I try to keep things really simple, but I do like to steer people towards what we would call a Mediterranean style of eating. And really, to summarize, that means a lot of fresh foods, mostly vegetables, and then proteins in the form of lean proteins such as fish or legumes, nuts, and then good fats in the forms of plant fats, olive oil, avocado, that type of thing. So it is true that fruits and vegetables are good for you. And again, that doesn't probably come as a surprise, but it's funny how we don't think about it a lot in our daily life and think about, what did I have today in terms of fruits and vegetables? And sometimes you can go a whole day without eating a whole lot of vegetable matter. So I think it's important that every time you eat, you kind of think about, did I have a vegetable with that meal? You know, maybe I had a tuna sandwich, but did I also have an apple or some carrots? So adding that in. There's been a ton of epidemiological study of diet and health, and it's just very obvious that the more fruits and vegetables that people eat, their risk of heart disease and and other chronic diseases, to be honest, are reduced. To that point, there's a ton of emerging evidence that the risk factors for heart disease, which we've just been talking about, are also risk factors for certain types of cancer. And it's not to say that, oh my gosh, if you have high blood pressure and high cholesterol, you're also going to get cancer. It's just that there's a lot of connection in the body to all of these things. So basically, improving your heart health and improving lifestyle that way can reduce the risk of certain types of cancer and other chronic diseases. So, as I just said, okay, have a sandwich, but also have an apple with it, or reach for bell peppers instead of reaching for chips. So I like to focus on eating broadly and well, and not telling people you can't have X, Y, and Z. I just find I like the enhancement mindset better than the deprivation mindset. And like I said, eating fruits and vegetables, high fiber foods, minimally processed or unprocessed foods, and good fats. We talked about protein, lean protein, high quality protein, and not super fatty protein. Basically, this. So, as mentioned, I'm not a low-fat person. That was kind of in vogue in the 80s. But it's more like there are fats that are better for your body, and there are fats that are not as good for your body. So, for example, trans fat is actually a chemical that's made in a lab, and it really doesn't belong in our diet at all. And that's found in a lot of processed foods. And then saturated fat comes primarily from animal products. So high-fat dairy, fatty meat, that type of thing. But the fats that come from fish, nuts, avocados are really good for you. They contain monounsaturated and polyunsaturated fats. The other part of the nutrition pie is portion size. So almonds are definitely good for you, but a 2-pound bag of almonds in a day is going to be a lot of calories. So we just need to be mindful of filling our plate with vegetables, adding a little protein, adding some more, not refined carbohydrates, but more dense carbohydrates maybe, and again, more fruits over here. So portion sizes with a big part of the plate being vegetables. Try to keep it simple. Should you take a supplement? There's a lot out there. There's a lot of things you can buy and spend money on. I'm not a huge fan of a lot of different supplements, and I do think that if you eat a variety of foods, you're going to get most of what you need. The vitamin D story is a little bit controversial, and I think that the relationship between low vitamin D and heart disease has more to do with the fact that often people who have low vitamin D might have other lifestyle factors that increase their cardiovascular risk. So we don't across the board recommend high-dose vitamin D supplementation, but it can be an individualized decision. Calcium is also a little bit controversial. We used to recommend very high doses of supplemental calcium, especially in women, to promote bone health. And the current recommendation, especially for people who do not have osteoporosis, would be to get almost all, if not all, of your calcium intake from foods, whether that's low-fat, no-fat dairy, certain types of fish, leafy green vegetables, and then maybe adding a little supplementation, but we do not recommend high-dose calcium supplementation unless there's a very specific reason. Vitamin E, high-dose vitamin C, and some other vitamins that have been touted don't have a clear benefit unless someone is pregnant, and then they should take folate. So moving on to the second pillar, not surprising, nutrition and exercise are very important. And really, we should all be moving at least 30 minutes most days of the week, and then building up extra movement during the day, walking up the stairs, taking the bike instead of the car, moving around at lunch, going for a walk at lunch, standing at your desk. Some exercise is better than none. So if it's a day that you're really busy and you feel like all you have time for is a 10-minute walk, yeah, do the 10-minute walk. It may not be as much as you would like, but it's much better than nothing. There's a lot of data that after eating a meal, Even literally walking for 2 or 3 minutes really improves the spike in blood sugar that happens after we eat and kind of helps the insulin, glucose, glycogen system get back in sync. So exercising lightly after eating is another good way to kind of build that movement in and also help with blood sugar. And I'm a fan of variety, as you can tell, variety in your diet, lots of different vegetables, variety in your exercise. Do what you like. I mean, if you like walking, awesome, walking's awesome. If you like taking a dance class, and then adding in some other things, like maybe a day or two a week where you're doing more strength training or flexibility, just kind of keeping your body guessing in a way, and doing some high intensity exercise, as long as it's okay with your cardiologist, have really shown benefit. I think part of it is it just keeps it interesting, but there's also a lot of good data that you accomplish more in less time. So variety is the spice of life, I guess you would say. I was an anthropology major in college, so it is true that we really don't move as much as we are meant to. Our technology and our lifestyle has evolved more quickly than our physiology, and we're still meant to be kind of moving all the time and not eating all the time, so we gotta keep going. This is just a graphic, and to summarize, the more you exercise, the longer you'll live, to a point. But for most Americans, getting about 450 minutes a week of exercise, in this example it's brisk walking, can really improve your lifespan by up to 5 years. And also just makes you feel better in the moment too. So I'm actually reading a book right now, so this is very current, and I referenced the book at my last slide, but it's called Why We Sleep. And the more I read, the more impressed I am with how important sleep is for all health. Mental health, physical health, cancer risk reduction, heart disease risk reduction, cognitive benefit. There's a lot of data that older people who have been diagnosed with dementia may may have an underlying sleep disorder, and if we can help them sleep better, their cognition may improve. So this is really, I think, key. And the number is kind of high. 8 hours is great. 7 is probably okay, but really less than 7 or 6 hours, or less than 7 hours a night, people who chronically sleep 5 or 6 hours, it just takes a toll over time. And I don't know, this book is great, and I just wanted to bring that up, because I think as physicians, number one, well, when I was in medical school 100 years ago, it wasn't taught a lot, but the data about sleep is really impressive. We could go on, but poor sleepers tend to gain weight, have worse performance in general, and also increased risk of depression. And we talked about inflammation earlier in the talk, so sleep's great. This is a tough one, because we all have stress in our lives, and often we can't control it, nor should we try to control it. But if we can find ways to navigate it and manage it, and maybe take a few things off our plate, that can really help. If we can do less fight or flight and more just kind of rest, parasympathetic nervous system, that tends to be better for the heart and for the body overall. There's data that heart attacks are less frequent in the summer. People are on vacation, spending more time outside, maybe a little bit more relaxed. So, this isn't a lecture about stress or stress reduction, but it is part of the overall important pillar of health. Just as a quick aside, we do know that oral health and reducing periodontal disease, reducing cavities, and just getting regular cleanings and making sure that everything is good in the mouth is really important for the heart. Again, getting back to that inflammation, chronic inflammation, and trying to keep everything healthy. So we're one organism, it's all connected. I think specialists tend to focus on the heart and the vascular system, but really the longer I do this, it sounds a little bit simplistic to say, but really everything is connected. I don't really need to say too much about this slide. If you smoke, we'd love to help you quit smoking. It's very, very difficult to do. Talking to my patients who smoke, it's an incredibly hard habit, but we would love to help you with that. And as we finish up here, I just want to say that the whole sort of focus on enhancement and not deprivation, or focus on how can exercise be fun and not a chore, and just shifting the mindset around the word habit. I mean, do something because you know you're going to feel better. Like, I know I always feel better after I exercise, or after I've had a good night's sleep, or a really satisfying, healthy meal. I physically feel better and I mentally feel better. It's not magic, it's just true. And then over time, as you do these things and realize that they make you feel better, you're going to keep doing that. So that's how we build those patterns and those habits. I find that, you know, getting together with friends for a hike, or having certain people that you go to the gym with, or going on a bike ride makes things really much more enjoyable. And as mentioned, all of this that's good for the heart is good for overall health and reducing other chronic diseases such as dementia and cancer and immobility, and osteoporosis and diabetes, and we can go on. So some people who already have heart disease or who've had heart attacks, heart surgery, we're here for you. You know, I spent the majority of the talk talking about diet and exercise and all that sort of perhaps less glamorous stuff, but we do have really great medicines in our toolbox that are very important. It would be great if we lived in a world where we didn't need heart medicines, but the fortunate thing is we do. We have medications for blood pressure, medications for cholesterol, and it's really a multifaceted approach. I think sometimes people are frustrated when they've led a pretty healthy life, but they still end up with a heart stent, for example. And I would say, well, you can't choose your genetics, and we now have the lifestyle that you've all been doing, but we can add a couple of medications to further reduce your risk. So, you know, I'm certainly not opposed to medications, and they really are important for some people, controlling your diabetes. Aspirin, I will say a couple words about this. About a year ago, there was a big meta-analysis that came out, and it was all over the lay press about people shouldn't take aspirin anymore. And I want to take this opportunity to clarify that some people absolutely should take aspirin. Most of my patients should take aspirin. The message really was, aspirin is no longer recommended for everybody over 50, for example. I think there was a big trend when I was first starting my training that aspirin reduces the risk of heart disease. Heart disease is very common, therefore everyone should take aspirin. Aspirin carries a small bleeding risk because it is an antiplatelet drug, so it makes the platelets in your body slipperier, so they don't stick to that plaque and cause a clot. So that's why they're really good to reduce the risk of a heart attack or a stroke, which is basically a brain attack. But there's a little bit of bleeding risk associated with low-dose aspirin. So if you don't know if you should start aspirin, or if you're on aspirin and you don't know if you should continue it, check with your provider, with your primary care provider or other physician or provider that you see. But people who don't have a lot of risk, high blood pressure, diabetes, bad cholesterol, family history, probably don't need daily aspirin. So that was a sort of update / aside. So like we said, having had a heart attack or a stent in your heart or needing heart surgery does not mean that this is it. We have a lot we can do after the fact, and keeping in touch with your physicians, going to cardiac rehab are all very important things to do. So not to give up, but just kind of keep moving forward. I will leave this slide up because this is a resource slide. The book that I mentioned that I'm currently reading, I'm not done, but it's so good so far that I'm putting it on my slide, is this Why We Sleep book by Matthew Walker, who's a neuroscientist. But these are some books that I've read over the years and some websites that I found helpful for myself and for my patients. and I appreciate everybody's attention. I'd be happy to take a few questions.
Thank you, Dr. Ware. That was very informational. We appreciate that.
Thanks.
We want to remind our audience that now is the time to submit any questions in the chat box. We do have a few, but we can take more, so let us know. These are in no particular order. I'll just get these going for you. Does Boulder Heart offer screening tests for inherited genetic assessment of cardiovascular risk?
So that's a great question. One of my partners, Dr. Nelson Trujillo, works closely with a company that's in Boulder called SomaLogic, and they're doing some studies about certain proteins in the blood that portend cardiovascular risk. We can certainly get more information from Dr. Trujillo about who are we offering this to and whether they're still kind of in the study phase. So that's one thing that he's doing within our practice. We don't do a lot of genetic testing in general, partly because genetic testing, I think, is best done by a professional genetic counselor who can kind of help us understand, well, if one person has it, then has the gene, does their kid get tested, and that type of thing. So the answer is yes, we're starting to, but not a full range. But we can certainly get more information about the SomaLogic data from Dr. Trujillo.
Okay, thank you. What is the typical life expectancy of a person with severe heart disease, excluding heart transplants?
Tough question to answer because, as we said in the beginning, heart disease, and maybe this person is referring to blockages with a history of stents or bypass, but heart disease could also be heart failure, which is reduced muscle function, or heart arrhythmias. So the average life expectancy, I believe, in the United States is somewhere around 80 and maybe 82 for men and maybe 82 for women. Just read this statistic a couple of weeks ago. But you know, a lot of people who come in and see us with a heart attack or needing stents, they go on to live normal life expectancy. So it depends a little bit about what the initial insult was, and so I'm not sure I can answer the question specifically, other than to say there's primary prevention where, hooray, you haven't had a heart attack, let's keep it that way. And then there's secondary prevention is, okay, you had one, let's help you not have another one. And we work on both. I will say, obviously, there are patients in our practice who've had more than one heart attack, but a lot of our patients, once they're on the meds and once they're plugged into their exercise program, end up being very, very stable over a long period of time. So that's a very general answer.
Yeah, that is fairly broad, but thank you for addressing that.
Of course.
Why is my sleeping heart rate higher than my resting heart rate?
That would be not normal. And that's another thing that we're integrating into our practice. As you can imagine, there's a lot of data coming at us from Apple Watches and Fitbits and cardio monitors and Oura rings, and we have to be mindful as physicians about how we interpret that, whether data from a watch is sufficient for a diagnosis or whether the person may need some more testing. So I would say if someone's heart rate during sleep, based on a wearable, I'm assuming, is higher than daytime resting heart rate, maybe there's an arrhythmia going on, so there may be something like atrial fibrillation or some other kind of arrhythmia that's happening at night, and that is not uncommon. If someone came into clinic with that concern, I would say, hey, let's have you wear a heart monitor, which is like a little sticker that's about this big for a week or so, and see what's really going on, so to kind of corroborate or correlate with the data that they've gotten from their wearable. So I would say that description is not normal and probably warrants further evaluation.
Okay. this person is asking if they need a stent, what is the material made of, and should they have an allergy test before the stent is placed?
Good question. So I have never heard of someone having an allergy to a stent that was implanted, and as you can imagine, there have been millions of stents implanted across the world. I guess I wouldn't stand up here and say that could never, ever happen, but we've never, to my knowledge, allergy tested someone before a stent. Most stents are made out of kind of some form, like a titanium, kind of thin, flexible titanium type mesh, and they're very, very tiny because the arteries themselves are really on the order of a few millimeters wide. And just to explain, because it's really cool, the stent comes not deployed and it gets put down the artery over a wire by one of my interventional partners. And then the stent gets expanded over a balloon so it kind of crushes the plaque to the side, and then that eventually becomes part of the wall of the vessel. So no allergy testing is needed, and it's usually some form of flexible titanium is my understanding of it.
Is there any truth to the saying, a glass of red wine per day is good for you and your heart?
So actually, thank you for that question. I didn't talk about alcohol at all in this talk. I think I've given this talk several times and sort of tweak it to be as current as possible. So when I first started in practice, we did literally say that. We're like, I don't know if I said the word you should have a glass of wine, but I said, yeah, drinking in moderation seems to be good for people. And as we collect more data over time, it turns out that alcohol is not a health food. I think that if people enjoy drinking alcohol in moderation, that is probably okay. But of course, there are a lot of people who struggle with moderation, and those people probably shouldn't drink at all. And then I don't recommend that people that don't drink have drinks to help their heart. There are so many other things that we can do. Guess what? Alcohol really disrupts your sleep. So getting back to my new favorite subject, alcohol before bed or even at dinner can really wreck the sleep architecture and the balance of REM and non-REM, and it's fascinating. But so the answer is I wouldn't recommend it. I don't think that it's the worst thing that someone can do for their heart. I think smoking cigarettes is way worse. And moderate alcohol by definition is a drink or less per day for women and 2 drinks or less per day for men. I like to say something like 3 drinks a week, not all on the same day. I would define that as moderate. I think 2 drinks a day seems like a lot. So a roundabout way of answering your question, but it does affect sleep.
Thank you. So this person said, hi, Dr. Ware. Thank you for all that you do for our community and heart health. So just a shout out for you.
Aw, thanks.
So you kind of touched on this. Do you have like a particular medication that you start with in your prescription? I know you mentioned several of them.
Mm-hmm. So it depends on what we're treating. I mean, as you can imagine, I use a lot of statins, and statin is a group of medication that lowers LDL cholesterol and reduces the risk of heart attack and stroke. So medications in that group include, generically speaking, rosuvastatin, atorvastatin, simvastatin, pravastatin. So a lot of people have a viscerally bad reaction, a lot of people recoil when I start talking about statins because they've heard horrible things about them. Any medicine can have any side effects, of course. But statins are very widely prescribed, especially in my world, and usually very well tolerated. And I would say, I use this analogy that statins are to cardiovascular disease as penicillin was to infectious disease way back in the 40s or 18, whenever that was invented, because the use of statins have dramatically reduced the incidence of heart attacks and strokes. Sadly, 1 out of 4 people still die of cardiovascular disease, but people are living longer, needing less interventions, living better, in part because of statins. So if the question was, what medicine do I start with? It depends, but if someone has plaque in their heart and high cholesterol, absolutely statin would be top of the list there.
Okay. So we've heard a lot about COVID and the heart, sometimes with heart inflammation. Mm-hmm. Is there a relationship, and do you have any current information on that?
Great question, thank you. I give another talk every once in a while with athletes in cardiovascular disease, and so I talk a little bit about COVID there, but the short version is that, like any virus, influenza, Coxsackie, enterovirus, like many viruses can affect the heart, either directly by attacking the heart cells, or indirectly, meaning if a person has horrible pneumonia from COVID and they're on a ventilator and they're not getting enough oxygen, that's going to be huge stress on the heart. So sadly, COVID and other viruses can affect the heart. With the advent of vaccines, thank you, science, we're still seeing COVID, but it's just much less virulent in terms of disease severity. So we're seeing a lot less cardiovascular complications. As a general rule, more severe COVID cases have a higher risk of having cardiac involvement. Mild symptoms, asymptomatic, very unlikely to have cardiac involvement. In people who've had COVID infection and have over sort of several days to weeks after kind of the initial 10-day, you're gonna not feel great period, if they continue to have symptoms like chest pain or trouble breathing or palpitations, funny heartbeats, we should see you or see your primary care, because may need something like an ultrasound of the heart and an EKG. So we certainly take it seriously. The good news is I think that the severity of illness and the number of cardiac complications you're seeing are decreasing, which is great. But COVID is still here, and it's probably just going to become endemic, but I'm not an infectious disease doc.
Okay. Can you explain the risk from a heart murmur when you're older?
So a heart murmur has to do usually with the valves inside the heart. So there are 4 valves in the heart. They're like little doors. So they open and close as the heart squeezes and relaxes. So the blood can continue to move in one direction, and the blood doesn't go back and forth. So people can have leaky heart valves or narrowed heart valves. And generally when we say murmur, a murmur just means I hear something when I listen to your heart. So it's like saying blue jeans, but we need to understand the brand of blue jeans. So we would get more information. So if we heard a loud murmur that sounded pathologic, like, it's in a spot and has a quality to it when I listen to it that I think it might be, for example, aortic valve stenosis, the next step is an ultrasound of the heart. So murmurs generally should be evaluated. Murmurs are pretty common in kids, not a pediatrician. And some people say, I had a murmur as a kid and now I don't have a murmur anymore. And that's actually a very common thing. But if an adult has a murmur, then I would get an ultrasound of the heart and see what's going on with the heart valves. Because heart valve problems, unlike the coronary artery problems that we spent most of today talking about, aren't usually a lifestyle thing. It's usually a structural problem and may or may not require intervention surgically or with a catheter. So that's a different topic, but would need more information about a murmur.
So a couple of questions about food. Is peanut butter a good fat?
So I think so, in moderation. It's very calorically dense, so we have to keep that in mind. And I am not a food scientist, so I know that there's a lot of detail that people can get into about different kinds of polyunsaturated and monounsaturated fats and like the ratios, and are macadamia nuts better than peanuts? And I've sort of heard that that's concern. I think that probably, you know, spreading peanut butter on your toast is got a little bit more nutritional bang for your buck than spreading butter on your toast. So everything in moderation. And I maybe kind of like the wine. Is it health food? No, but is it a pretty good food to kind of have on your palate of food? Pun intended. Probably, yeah. But I think there's a lot of controversy around nuts. Like, are almonds better than walnuts? I don't know, but I think that nuts are probably pretty good food.
Okay. Are there some foods you should avoid if you have a stent?
Well, stents have to do with plaque and atherosclerosis, so high saturated fat, highly refined foods with a lot of sugar, those things promote inflammation. So heart-healthy diet applies to people with stents for sure.
Okay. Is race a factor?
So we're learning more, and we have to learn more about sort of, do certain ethnic and racial groups of people have higher risk of certain problems? I will say African American populations, Black people who identify as Black, but do seem to have a higher incidence of high blood pressure. I think that's multifactorial, and we're trying, and you know, we really, as a medical community, need to, in my opinion, understand exactly what's going on there. I'm also I have a lot of concern around health equity, and you know, clearly in this country, not everyone's getting the same access to care, and I think that's really important. That's one of my kind of torches that I like to carry in terms of ways that we can have everyone have access to care. I mean, maybe some people have never gotten their blood pressure checked. So I absolutely think that there are some certain groups that have different responses to physical stressors, environmental stressors, intergenerational stressors, and certain groups respond differently to different medications. Antihypertensives or anti-blood pressure medicines are a good example. So to answer the question, yes, we definitely need to take race into account when we're understanding somebody's risk and their background and how best to be treated. And that's super important.
Okay. So CIMT showed carotid plaque. Doesn't that need immediate attention? How do I mitigate it or treat it?
So carotid intimal media thickness is one of the slides that I showed. It's where someone gets a carotid ultrasound and there's a little bit of plaque buildup. So it's not necessarily an emergency. Generally, the next step would be, it's gonna take just 1 second, would be to get if this was just a screening ultrasound, perhaps to get a formal ultrasound that actually shows blood flow and blood velocity in the artery, and then kind of looking at everything else. Has the person had a stroke? Do they have plaque in their heart? How high is their cholesterol? So it's definitely a starting point, and it raises a little bit of concern, like, okay, there's some plaque buildup, what do we do about it? It's generally not an emergency though, but it's something that should be followed up.
Okay. What was the AIC number again?
Oh, the hemoglobin A1C is well, now I've thoroughly messed up my slideshow, sorry. We don't need it, but hemoglobin A1C.
It's not on, so you can just speak to it.
Oh, this is not on the screen?
Yeah, when you went to that, I didn't show it, but then I...
Great. Hemoglobin A1C. is basically what percentage of your red blood cells circulating in your body have sugar on them. And when people have diabetes, we like to keep that number below about 7%. And that's a endocrinology, primary care, sometimes cardiology. They're very intersected.
Okay. Should calcium score tests be repeated every few years?
Great question. I think it's reasonable to repeat a calcium score perhaps 5 years from an initial score, especially if the initial score were very low. If someone's got a high calcium score, 500, 1,000, the horse has left the barn at that point, and we really pivot to saying, you've got a lot of plaque in your heart. We need to talk about what that means. We need to talk about if you need a stress test, some other cardiac test that would give us more information about how much that plaque is affecting blood flow. People who have had stents, people who have had bypass surgery no longer need heart scans, because a heart scan is really a screening test. It's something that we would recommend in someone who has risk for heart disease but has not yet had any sort of event. So I would say maybe repeating a scan every 5 years in someone with a low score is reasonable to see change, but in a really high score or for someone who already has had a stent, we don't need to repeat it.
So does the high score mean that you do have heart disease?
Yes. So if someone has a calcium score on their heart scan, which is basically a CAT scan of the chest, I mean, really any number greater than 0 is technically a positive calcium score, but we don't panic about a score of 10 or 20, but sort of once we start sitting 100, in the hundreds, and then higher, that means that there's calcified plaque in the arteries of the heart. It may not mean that there's an actual blockage. You know, it could mean, think about like a shell. Think about that the calcium could just be lining the vessel and not actually encroaching on the lumen of the vessel, but we can't tell that from the heart scan alone. So that's when we talk to the patient. Do you have symptoms? Let's get an EKG. Let's think about a stress test. So it's something that can lead to more testing. But in medicine, we never want to order a test or perform a test unless we're prepared to do something with the results. So anything we do has the potential for downstream testing. But yes, if someone's got a score of 100 or more, or 50 or more, then there's significant plaque in the heart.
Okay. What is your experience with using Repatha? I have heard that there's a shot that can control the cholesterol. When would that be recommended?
These are good questions, guys. So Repatha is a new, it's part of a class of drugs called PCSK9 inhibitors, which are injectable. Twice a month is the most common. Once a month is another possibility. It's a subcutaneous injection like insulin, so it's not an intravenous injection, and people can do it at home. It is currently indicated for, and only paid for by insurance companies, patients who are not at their goal cholesterol on a statin, or who cannot take statins because of disabling side effects. So it is not the first-line therapy for high cholesterol, but it is very impressive in terms of how much it can reduce cholesterol. And we use it quite a bit, almost always in conjunction with statins.
Okay. So you've mentioned plaque quite a bit. Is there a test, especially if a family member has had plaque, not necessarily causing a heart issue, but a stroke? So,
So as as we talked about, it's all one vascular system. So people who have plaque in their carotid arteries or who've had a stroke because they have plaque in the vessels inside their brain, they are also at risk of heart disease too. So when people say that they've had multiple family members with stroke, I often treat that as kind of a heart disease equivalent. So getting back to, okay, you've got this impressive, or not impressive, but concerning family history, we need to figure out what your blood pressure is, does that need to be treated, what your cholesterol is, maybe you should be on aspirin, maybe we want to look at the carotid. So I hope I'm answering the question in the way that the person would like, but I do think of stroke as a cardiac event. We are not neurologists, so we don't primarily treat stroke, but a lot of our patients have had stroke. As an aside, there's also a type of stroke that can be caused by a blood clot from the heart that goes to the brain. That's related to a heart rhythm problem called atrial fibrillation. And we see, I mean, that's in our world as well.
Okay. One last question here, and for the rest of our audience, if we didn't get to you, we'll let you know at the end here how to submit your questions. We did get through most of them. Can diet and exercise affect inflammation?
Yes. Yes. So do it. It's good. It's the best medicines we have: diet, exercise, and sleep. Exercise acutely raises inflammation, but then for the other 23 hours of the day, you know, things are calmer. So eating well and exercising, getting enough sleep can reduce inflammation.